Good morning. My name is Tim Vincent, and this presentation will discuss shock, a life-threatening condition characterized by inadequate tissue perfusion and impaired oxygen delivery to the body's cells. Although shock can result from several different causes, all forms ultimately lead to cellular dysfunction and organ injury if not recognized and treated promptly. This presentation will examine the impact of shock on the United States population, its causes, pathophysiology, clinical manifestations, treatment, and current evidence-based nursing recommendations. Before discussing the different types of shock, it is important to first define what shock actually is. Shock is a life-threatening condition in which tissue perfusion becomes inadequate to meet the metabolic demands of the body's cells. Although many people associate shock with low blood pressure, hypotension is often a later finding. The underlying problem is inadequate oxygen delivery to tissues, preventing cells from producing the energy they need to function normally. Figure 2 illustrates the normal relationship between the pulmonary and systemic circulations. In the lungs, oxygen diffuses across the alveolar capillary membrane into the bloodstream, while carbon dioxide, a waste product of cellular metabolism, diffuses into the alveoli and is exhaled. The heart then pumps oxygen-rich blood through the systemic circulation, delivering oxygen to tissues throughout the body. Cells utilize oxygen to produce ATP through aerobic metabolism, while generating carbon dioxide as a metabolic waste product. Carbon dioxide is then carried through the venous circulation back to the lungs, where it is exhaled. During shock, this normal process begins to fail because tissues no longer receive enough oxygenated blood to meet their metabolic demands. As oxygen delivery decreases, cells shift from efficient aerobic metabolism to anaerobic metabolism in an attempt to continue producing ATP. However, anaerobic metabolism generates far less ATP and cannot sustain normal cellular function indefinitely. As ATP production falls, lactate begins to accumulate, metabolic acidosis develops, and progressive cellular dysfunction ultimately leads to tissue injury and organ dysfunction if adequate tissue perfusion is not restored. The cellular mechanisms responsible for this progression will be explored in greater detail later in this presentation. For now, it is important to recognize that shock is fundamentally a failure of oxygen delivery rather than a failure of oxygenation. A patient may have a normal arterial oxygen saturation while still experiencing profound shock if oxygenated blood is unable to adequately reach the tissues. Throughout the remainder of this presentation, I will discuss the impact of shock on the United States population, its etiology and risk factors, the underlying cellular pathophysiology, clinical manifestations, physician-directed treatment strategies, and evidence-based nursing care. Shock represents one of the most common medical emergencies encountered in hospitals and intensive care units across the United States. Rather than being a single disease, shock is the final common pathway of many serious illnesses, including severe infection, trauma, hemorrhage, myocardial infarction, and anaphylaxis. As shown on this slide, millions of Americans develop medical conditions each year that have the potential to progress to shock if they are not recognized and treated promptly. Septic shock is the most common form of shock encountered in critical care. According to the Agency for Healthcare Research and Quality, more than 2 million Americans were hospitalized with sepsis in 2021, resulting in approximately 300,000 deaths and more than $52 billion in hospital costs. making sepsis one of the most expensive conditions treated in United States hospitals. Although less common, cardiogenic shock remains one of the deadliest complications of acute myocardial infarction. It develops in approximately 5 to 10% of patients experiencing an acute myocardial infarction and continues to carry an in-hospital mortality rate of approximately 30 to 50%, despite major advances in reperfusion therapy and critical care. These statistics emphasize why early recognition and intervention are so important. Regardless of the underlying cause, prompt restoration of tissue perfusion greatly improves patient outcomes and reduces progression to irreversible organ dysfunction. As we move into the next slide, we'll examine the major causes of shock and how seemingly different disease processes ultimately converge on the same pathophysiologic endpoint. Shock is not a single disease, but rather a physiologic syndrome with multiple underlying causes. Although the mechanisms that initiate shock differ, they all ultimately converge on the same endpoint: inadequate tissue perfusion and insufficient oxygen delivery to tissues. As shown in Figure 3, there are 4 major categories of shock. Cardiogenic shock occurs when the heart is unable to pump effectively, resulting in reduced cardiac output despite an adequate circulating blood volume. Common causes include acute myocardial infarction, severe heart failure, and life-threatening dysrhythmias. Hypovolemic shock results from a significant loss of circulating blood volume. Hemorrhage remains the most common cause, although severe dehydration and extensive burns may also produce hypovolemia by reducing intravascular volume. Distributive shock differs from the previous 2 etiologies because the problem is not inadequate blood volume or pump failure, but rather profound vasodilation and abnormal blood distribution. Septic shock is the most common form of distributive shock, while anaphylactic and neurogenic shock represent additional causes. Finally, obstructive shock occurs when a mechanical obstruction prevents adequate cardiac filling or blood flow. Examples include massive pulmonary embolism, cardiac tamponade, and tension pneumothorax. Although these 4 categories represent different mechanisms, they all reduce effective tissue perfusion. This common pathway explains why patients with very different underlying illnesses often develop similar clinical manifestations of shock. In the next slide, we'll follow this common pathway to the cellular level to understand how inadequate tissue perfusion ultimately leads to organ dysfunction. Although the underlying causes of shock differ, every form of shock ultimately follows the same pathophysiologic sequence. The process begins with inadequate tissue perfusion, meaning cells no longer receive enough oxygenated blood to meet their metabolic demands. Under normal conditions, oxygen allows cells to efficiently generate approximately 30 to 32 molecules of ATP from each molecule of glucose through aerobic metabolism. ATP serves as the primary energy source for virtually every cellular process, including membrane transport, protein synthesis, muscle contraction, and maintenance of electrochemical gradients. As illustrated in Figure 4, reduced oxygen delivery forces cells to shift from aerobic metabolism to anaerobic metabolism in an attempt to continue producing ATP. Although this adaptation temporarily supports cell survival, anaerobic metabolism generates only about 2 ATP molecules per glucose, making it far less efficient than aerobic metabolism. Lactate accumulation reflects the cell's shift to anaerobic metabolism and serves as an important clinical marker of inadequate tissue perfusion. As ATP production declines, lactate begins to accumulate and metabolic acidosis develops. The acidic intracellular environment, combined with ATP depletion, progressively impairs normal cellular function. Energy-dependent membrane pumps, particularly the sodium-potassium ATPase pump, begin to fail. Sodium accumulates within the cell, water follows by osmosis, and cells begin to swell. If tissue perfusion is restored early, these changes may still be reversible. However, prolonged hypoperfusion results in widespread cellular injury, mitochondrial dysfunction, activation of inflammatory pathways, endothelial damage, and progressive tissue injury. As more organs become affected, patients develop multiple organ dysfunction syndrome, or MODS, which represents one of the leading causes of death and severe shock. Understanding the cellular progression explains why restoring tissue perfusion as quickly as possible is the primary goal of shock management. Every treatment discussed later in this presentation ultimately aims to interrupt this cascade before irreversible cellular injury occurs. As shock progresses, the clinical manifestations reflect the body's attempt to maintain perfusion to vital organs. During the early or compensated stage of shock, activation of the sympathetic nervous system produces tachycardia and tachypnea, while peripheral vasoconstriction redirects blood flow toward the heart and brain. As a result, patients will often present with cool, pale skin, delayed capillary refill, decreased urine output, and feelings of anxiety or restlessness. If tissue perfusion continues to decline, the body's compensatory mechanisms eventually become overwhelmed. As shown in figure 5, inadequate oxygen delivery begins affecting multiple organ systems. Patients may develop hypotension, altered mental status, weak peripheral pulses, worsening oliguria, elevated serum lactate levels, and metabolic acidosis. At this stage, organ dysfunction is becoming increasingly apparent. Continued hypoperfusion can lead to serious complications involving nearly every organ system. Common complications include acute kidney injury due to reduced renal blood flow, acute respiratory distress syndrome resulting from widespread inflammation and increased pulmonary capillary permeability, disseminated intravascular coagulation caused by abnormal activation of the coagulation cascade, myocardial ischemia due to an inadequate coronary perfusion, and ultimately multiple organ dysfunction syndrome, or MODS, which remains one of the leading causes of death in patients with severe shock. Recognizing these clinical manifestations early is critical for nurses because treatment is most effective before irreversible organ injury develops. The next slide will discuss the primary treatment strategies used to restore tissue perfusion and interrupt this progression. The primary goal of shock management is to restore adequate tissue perfusion before irreversible cellular injury develops. As discussed in the previous slides, every treatment strategy ultimately aims to improve oxygen delivery and interrupt the pathophysiologic cascade leading to organ dysfunction. Initial management begins with stabilization of the airway, breathing, and circulation. Supplemental oxygen or mechanical ventilation may be necessary to optimize oxygenation, while continuous hemodynamic monitoring allows clinicians to assess the patient's response to treatment. Intravenous or intraosseous access should be established promptly so that fluids, medications, and blood products can be administered without delay. The next priority is restoring tissue perfusion. As shown in Figure 6, isotonic crystalloid fluids are commonly administered for patients with hypovolemic and septic shock to improve intravascular volume. If hypotension persists despite adequate fluid resuscitation, vasopressors may be required to maintain organ perfusion. Current guidelines recommend norepinephrine as the first-line vasopressor for most patients with septic shock because of its effectiveness and favorable safety profile. While supportive therapy is essential, definitive treatment depends on correcting the underlying cause of shock. Patients with septic shock require early administration of broad-spectrum antibiotics and source control. Hemorrhagic shock requires rapid control of bleeding and blood product replacement. Cardiogenic shock may require coronary revascularization, inotropic support, or mechanical circulatory support, while obstructive shock requires prompt relief of the mechanical obstruction, such as thrombolysis for a massive pulmonary embolism or pericardiocentesis for cardiac tamponade. Throughout treatment, patients require frequent reassessment of blood pressure, urine output, serum lactate, mental status, and other indicators of tissue perfusion to determine whether interventions are improving organ function. Early recognition, rapid intervention, and continuous reassessment remain the cornerstones of successful shock management. Nurses play a critical role in the early recognition, treatment, and ongoing management of patients experiencing shock. Because nurses are continuously assessing patients at the bedside, they are often the first members of the healthcare team to recognize subtle signs of worsening tissue perfusion before profound hypotension or organ failure develops. Evidence-based nursing care begins with frequent assessment of vital signs, mental status, skin perfusion, urine output, and other indicators of end organ perfusion. Trends are often more important than a single abnormal value. For example, a rising lactate level, decreasing urine output, or new confusion may indicate worsening shock even when blood pressure initially appears stable. Timely intervention is equally important. Nurses administer intravenous fluids, vasopressors, antibiotics, blood products, and other therapies as prescribed, while closely monitoring for therapeutic response and potential complications. In patients with suspected septic shock, current guidelines emphasize obtaining blood cultures when appropriate and administering broad-spectrum antibiotics as early as possible because delays in treatment are associated with increased mortality. Continuous reassessment remains essential throughout treatment. Nurses evaluate hemodynamic status, urine output, serum lactate trends, laboratory findings, and overall clinical response while communicating significant changes to the healthcare team using structured communication methods such as SBAR. This ongoing assessment helps guide treatment decisions and supports timely escalation of care when needed. Ultimately, evidence-based nursing practice improves patient outcomes through early recognition, rapid intervention, effective communication, and continuous reassessment. By understanding the underlying pathophysiology of shock, nurses are better equipped to recognize deterioration, prioritize interventions, and help prevent progression to irreversible organ failure. Although the causes of shock vary, every minute of delayed recognition increases the risk of irreversible cellular injury. Understanding the pathophysiology behind shock allows nurses to recognize deterioration early, intervene quickly, and ultimately improve patient outcomes. In closing, Although the causes of shock vary, they all ultimately lead to the same outcome: inadequate tissue perfusion and oxygen delivery to the tissues. Understanding this pathophysiology allows nurses to recognize subtle changes and signs of deterioration early, intervene promptly, and help prevent progression to irreversible organ failure. As nurses, our ability to recognize shock early and respond quickly can have a direct impact on patient outcomes. Thank you for your time, and I'll be happy to answer any questions.